So now, without any further delays, I would like to invite Dr. Sabri for the lecture on hip trauma. Welcome, Dr. Sabri.
Thank you for the committee that invited me to this virtual regional anesthesia workshop of EDHKL. And today I would like to share about this hip trauma, how we can use, we offer the multimodal analgesia to counter the pain of hip trauma patient by using our PENG block and fascia iliaca in compartmental block. So today I would like to talk about the innovation to the hip joint, the block technique for both of the FICB and PENG, and comparison of both also. So first of all, the indication of the FICB and PENG block very various. That I can say first for analgesia for hip trauma and fractures. Either patient will go to arthroscopy surgery or convert to arthroplasty, and also analgesia before mobilizing the patient, either mobilize the patient from ED to the ward, or from before we put the patient either epidural or spinal anesthesia in the operation theatre. Also, this FICB and PENG block can use for to tackle cancer pain management or chronic hip pain, and also can give for the hip dislocation patient, and can as so-called anesthesia for medial thigh and vein ligation surgery or stripping of varicose vein surgery, which the extended volume 30 to 40 mils of half maximum concentration dose for anesthesia. So-called like if we use ropivacaine, we can use about 0.375%, or we use the chirocaine or levodopa, we can use 0.25%. So this is the anatomy, the body structure of the hip joint. The most important is our axis, anterior superior iliac spine from the iliac bone, coming to the anterior inferior iliac spine, coming down to the iliopubic eminence and pubic rami, and also this obturator foramen. This schematic of lumbar plexus and lumbosacral plexus, very messy, right? So actually, this is on the background of the psoas muscles, and then the iliacus muscle, and also piriformis muscles. So this lumbosacral is not so messy like the brachial plexus just now. From the root of the lumbar and sacral spinal muscle nerve, they will divide into the branches, terminal branches. They not distinguish the truncal, the cord, or the division like the brachial plexus. So from the anterior and posterior division just now, okay, for the anterior division of lumbar plexus, they give rise to the iliohypogastric nerve, ilioinguinal nerve, also femoral nerve, and the last one is obturator nerve, whereby the posterior division of the lumbar plexus will give off the femoral cutaneous, the most lateral side, and then the femoral nerve as well. For the sacral plexus division, will give rise to this sciatic nerve of the tibial component, and then the pudendal nerve, and then the posterior femoral cutaneous nerve. And the last one is the posterior division of sacral nerve, will give rise to the perennial component of the sciatic nerve, and then the piriformis nerve. Okay, so the innervation, if we can divide into anterior and posterior of the hip joint, the anterior part is nociceptive component, which is innervated by femoral nerve, obturator nerve, and accessories obturator nerve, whereby the posterior side from the sacral plexus is a proprioceptive component from nerve to the quadratus lumborum, superior gluteal nerve, and muscular articular nerve. And then we talk further from the anterior point of view. they divide into superior, inferior, medial, and lateral. So they divide into 4 quadrants, which is the most nerve lies at the inferior lateral quadrant, which is femoral and obturator, and also inferior medial quadrant, innervated by femoral, obturator, and accessory obturator nerve. Okay, so this very crucial, means very important structure when we perform the fascia iliaca and also PENG block. When we position our probe at the beside the axis or femoral inguinal ligament, so we can view from superficial to deep structure. After the soft tissue, we can reach the fascia lata. Below that is fascia iliaca, and then below the fascia iliaca comes our femoral nerve, femoral artery, and femoral vein, superficial to the psoas and iliacus muscles. And below that is our articulate branches of femoral nerve, where the inside the psoas muscles. And this also medial to medial of that got accessories obturator nerve, and more medial we can get the obturator nerve. So they did the anatomy study of innervation of the interior hip capsule. So they dissect the 13 hemifabric cadaver, and then what they found out is the hip joint innervation, the anterior capsule, primary by the femoral nerve, obturator and accessory obturator nerve, and secondary, the small muscle is by the nerve to the psoas and nerve to the rectus femoris. Oh, everybody boring, is it? Okay. And then the posterior capsule, the primary is innervation, but the innervation by the superior gluteal nerve and inferior gluteal nerve, and also sciatic nerve. And secondary means that the muscle component is nerve to quadratus femoris, either posterior medial, posterior superior, and posterior inferior. Okay, so we come to the more interesting part, how to block, to do block. The first one is fascia iliaca compartmental block. So actually, fascia iliaca compartmental block, or FICB, is principally is a extension of the femoral nerve block. In different of, actually we give more volume. If we give 20 mils for femoral nerve, for this FICB, we extend the volume to 30 to 40 mils of half maximum concentration, as what we mentioned before. And then using the needle about 50 mm, this block can cover for femoral, lateral femoral cutaneous, and or can cover obturator nerve. So previously, this FICB also known as the 3-in-1 block. So they said this block is good analgesia associated with hip pathology, either fracture or pre or post operation pain management, and then can use a various approach. Either we can use landmark technique, infra-inguinal or supra-inguinal. First, I will talk about this landmark technique first. So how to do this landmark technique? We draw a imaginary line from the pubic tubercle and axis. We divide into 3 divisions. The 1/3 from 1/3 lateral, 1 centimeter below. This is the injection point of the landmark technique of FICB. So we can inject about 30 to 40 mils of our local anesthetic agent, and then make sure this local will spread laterally to cover this lateral femoral cutaneous nerve, and medially to cover femoral nerve. And if we are lucky, the LA will spread beyond the pectineus muscle to cover the obturator nerve. So now we go to the other approach, which is supra-inguinal caudocephalic approach. They divide into 2 technique, which is one dual view iliacus plane technique. Okay, so same as when we scan to do the femoral nerve, position our probe at the before this, we know that got Mickey Mouse point, and then the snowman point. So for this, we use the snowman point, And then from the femoral nerve, just like the probe laterally until we reach the most, the iliacus muscle is the most superficial. And then after that, we mark with the finger here, the middle point of the transducer, and then rotate the probe horizontally to the axis. Imagine that these fingers is the injection point of our needle letter. So this is a dual view iliacus plane technique. And then the other one is FICB, which is supra-inguinal caudocephalic approach. And then this is a direct longitudinal axis technique. How we did? First, recognize our axis. Oh, sorry. Should be here. Okay, should be this axis, and then just place one finger medial to the axis, and then position again our probe just medially to the finger, and then we aim the caudal end of this transducer at the inguinal ligament. Okay, and then at this point we can view this sonoanatomy, which is we can view the anterior iliac, interior inferior iliac spine, and then this is our fascia iliaca actually. Okay, so give about 30 to 40 mils of injection, and make sure our needle comes from caudate to cephalic, and then make sure we can see this dorsal circumflex iliac artery, and then when we give our local anesthetic drugs, make sure that this artery is not compressing down. Okay, and then we need to make sure that our local spread downwards here to cover the pelvic area. So that when we give the local will spread like this. Okay. The local we need to make sure they spread laterally and proximally. So this is the last technique approach of the infra-inguinal lateral to medial approach of FICB. So position the patient same like we want to do the femoral nerve block, but slide the probe a bit lateral towards the axis, and then give the injection from lateral to medial in plane technique with the same needle and the same concentration and dose of local anesthetic drugs. So like this, from this is femoral nerve, scan lateral side, and then we can see this fascia iliaca here, and then the local anesthetic agent, make sure that the local is spread laterally below the lateral muscle, and then cover lateral. Okay, so we go to the last. Okay, so this is a quite new technique described by Drs. Philip PENG, Laura Guerin-Erengo, Ko Jin Ching, and Richard Bruhl, and Anahi Barras in 2018. Only about 2 years plus age of this block. They said that hip fracture patient is a common orthopedic emergency in elderly especially, and then with significant morbidity and mortality rate. And then our popular regional anesthesia analgesic strategy so far, so-called we use femoral nerve block, fascia iliaca block, or femoral 3-in-1 block. The effect is not so good. The analgesic cover is only moderate, and then some literature said optic nerve always not cover. So they said actually the anterior hip capsule is innervated by mainly the femoral nerve, optic nerve, and accessory optic nerve. And then this anterior capsule is most rich innervated part of the hip joint. So this nerve should be the main target actually for this hip analgesia. They said also the high articular branches from femoral nerve, accessories optic nerve, are consistently found between the AIIS and iliopubic eminence. Because of this info, so they come out this upper ultrasound guided technique for blockade of these articular branches to the hip. So this comes the PENG block. Okay, so actually PENG block is a interfacial block, targets the articular branches, the accessory part of the femoral nerve, occipital nerve, and also the accessory occipital nerve between the AIIS and iliopubic eminence. So with this technique, potential metal sparing effect is very good. So it means we don't have the motor block, and then patient can get early ambulation, and then surgeon also like. They did study a case series of 5 patients with hip fracture, and score is very good. Okay, all patients with significant reduced pain score and no quadriceps weakness. So this they are published in brief technical report in 2018. So they said very good. All the 5 patients after 30 minutes, the pain reduced from 10 to 2 and at least from 7 to 3. This very good block described by them. So how to do this block? Position the patient supine, and then with the either curvilinear probe or linear probe with high frequency probe, position the probe at the horizontal of the axis. Okay, over the axis, and then align the probe. Okay, counter clockwise, rotate 45 degrees towards the pubic ramus. Okay, and then from this, slide the probe medially towards the pubic rami. Okay, at this imaginary line, and then at this point we can see our iliacus muscles, psoas tendon, our femoral artery, our femoral vein, our iliopubic eminence, and maybe we can see this pectineus muscle as well. Okay, and then at this point we can inject from lateral to medial. Inject can use about 80 to 100 needles, also with the same volume of local anesthetic, also same concentration, about 30 to 40 mils. And then we inject, observe the LA will cover below this psoas tendon and just above the pubic rami. Okay. And then after we give the LA, make sure the LA is spread here also. And then if patient either big size, muscular, or maybe obese, we can use the curvilinear probe to see more structure. And then maybe we need a higher and longer needle as well. And then make sure the local is spread beyond this psoas tendon. Okay, so this is a comparison in between FICB and PENG block. You can choose either one. FICB is older block. PENG is young block. Okay. With FICB, maybe the occipital nerve will spare. So the pain may be moderate reduction in pain, but with PENG block, the lateral femoral cutaneous nerve will spare also. So, but better pain reduction of the hip trauma patient. And then with FICB, we can maybe get the motor block because they block the femoral nerve directly. But the PENG block, the motor sparing effect is good. So patient can early mobilization. And they said PENG block is faster onset. So the choice is at your hand. With that, I would like to say thank you.
Thank you very much, Dr. Sabri, for the enlightening talk. Before we proceed to the demo, we will have a few minutes break for the viewers at home to stretch your legs, have some coffee.
Assalamualaikum and a very good morning. In this video, we will show you how to perform fascia iliaca compartment block as an analgesic modality for hip trauma. There are two approaches for this block. The first one is infra-inguinal, lateral to medial approach, and the second one is supra-inguinal, CAUDO CEPHALAD approach. In this video, we will show you supra-inguinal approach with direct longitudinal axis technique. Patient in supine position. First, we identify anterior superior iliac spine laterally. Place an index finger immediately medial to the axis. Align a high frequency linear transducer immediately next to this finger with the caudal end of transducer just above the inguinal ligament. Alignment of this transducer should be superior medial to inferior lateral from cranial to caudal. We are using Stimuplex Ultra 360 80mm needle using in-plane approach. Here the needle already pierced the first fascia, which is fascia lata. Now the needle is approaching fascia iliaca. This is the sonoanatomy that we need to identify. The most superficial fascia is fascia lata. Just beneath this is fascia iliaca. DCIA, deep circumflex iliac artery, lies above fascia iliaca and iliacus muscle lies below it. Two muscles you need to identify are the internal oblique and sartorius muscles at the both ends. Ilium is identified as rounded, hyperechoic rim with hypoechoic shadow below it. Some describe this as bow tie sign. Both ends of the bow tie represents the muscle. On the cephalad side is internal oblique and on the caudal side is the sartorius. So here we can see that the needle already pierced the fascia lata, which is the first fascia. Now the needle is just above the fascia iliaca. Once we feel a pop, then we are sure that we are in the fascia iliaca compartment. Once we are here, we aspirate and make sure there is no blood. If it's clear, we are going to inject our LA. We are using ropivacaine 0.2%, 20 ml of volume. We can use up to 40 ml as long as it does not exceed the toxic dose. So here we are going to inject our LA. As you can see, the LA spreads very nicely towards cranially, and if the spread more cranially, then there is possibilities it will spread to the lumbar plexus. Okay, so there is some space created by the LA, so we are going to dive in a little bit our needle and we inject some more LA into that space. So now we are going to check the spread of our LA. We put back our transducer along the inguinal ligament and we identify the femoral vessels, femoral nerves, and the fascia iliaca. So the LA, there is some LA in the compartment. So thank you. Assalamualaikum and hi. PENG stands for Pericapsular Nerve Group. It was first introduced in late 2018 by a group of regionalists primarily from Canada. It is an interfacial plain block aiming to block articular branches supplied by femoral, obturator and accessory obturator nerve. It is an easy regional technique to perform in supine position with motor sparing benefit. It targets only the sensory branches and not the posterior mechanoreceptor. It involves deposition of LA in the musculofacial plane between psoas muscle and the superior pubic ramus. There are two approaches to perform PENG block. First approach is using low frequency curvilinear transducer over the anterior inferior iliac spine in the transverse plane towards pubic symphysis. Second approach is using high frequency linear transducer along the inguinal ligament. In this video, we will show you the second approach. Transducer is moved cranially about 1 to 2 cm above inguinal ligament to visualize femoral vessels, femoral nerve, anterior inferior iliac spine, psoas muscle, psoas tendon, and iliopubic eminence. Some describe the appearance of anterior inferior iliac spine and iliopubic eminence like a spoon. We call it as spoon sign. We have the head of the spoon and the tail of the spoon. This is the iliopubic eminence and this is the anterior inferior iliac spine. The pubic tendon lies above the head of the spoon. Once identified, we can inject lignocaine 2% to numb the skin. We are using Stimuplex Ultra 360 100 mm using in-plane lateral to medial approach. To avoid hitting anterior inferior iliac spine, adjust the needle by decrease the angulation, which then takes the needle away from the target towards the superior pubic ramus. We also can purposely advance the needle and hitting the iliopubic eminence. Then we draw our needle by 1 to 2 mm. Deposit our local anesthetic between pubic tendon anteriorly and pubic ramus posteriorly. We inject ropivacaine 0.2%, 20 to 40 mL in this plane. Ideally, LA should track medially beyond the iliopubic eminence in order to block the obturator nerve and accessory obturator nerve, which are more medial. Pubic tendon will then appear floating above iliopubic eminence. For optimal hip trauma analgesia, we suggest to combine PENG with lateral femoral cutaneous block. Just to remind, an upward tracking of LA will indefinitely cause a motor blockade due to possible blockade of femoral nerve. Thank you.